Hi, I'm Marlene Walchuk. I was diagnosed with Parkinson's when I was 59. I'd been having symptoms since January of 2015. Initially, before the diagnosis, before I saw the internist, I was afraid of the answer I would find. And I can do the Dr. Google thing and all that, but I didn't do it. I was just, I don't know, I was just stymied. I have always done a little bit of sewing. Anyway, I was making a duvet cover, and I got through that task of making that duvet cover. It was so hard to thread the needle. And I know when I put the sewing machine away at that time, I thought, I'm never going to sew again. This is it. I'm putting this away. It was with great trepidation that I took that first medication. I just thought, oh my goodness, this is going to be, I'm going to be on this for the rest of my life. Where is this going to go? And then, after that drug kicked in, within a matter of minutes, I could have just done a happy dance, because it was like, oh my goodness, I can move again. I think the toughest time was the time of the half a year before I got the medication. And since then, it's been quite a journey of managing medications and food and exercise. Here it is, how many years later? Eight years later. And I can pull my sewing machine out and do a little patch, whatever. So, yeah, the drugs are not a cure, but man, they sure help us manage the symptoms. I am definitely in favor of more Alberta research, and I guess more rural Alberta research for the future prevention and for the future generations. And being a rural Albertan, like when I just look at the stats and all, okay, right here near me, there's a fellow nearby who has Parkinson's. There's 2 other people living nearby, a new diagnosis of Parkinson's. And I mean, this is rural Alberta. So what I look at also for research is, again, for my children and my family, as I understand it, my children have a higher chance of getting Parkinson's disease than the average public. So it was really important to me to be involved in research that maybe they can find something out through my involvement and have a better future. Parkinson's can really, in my experience, really just slow you down and grind things to a halt, and you can be filled with despair, I think. Every flower must grow through dirt, and Parkinson's has certainly given me some dirt, but I am a flower, and I can rise above. Our challenges, it's in our challenges that we're strengthened, I guess.
A true story from Lisa, a Bayshore caregiver. Margaret doesn't like to soak in the tub, but she does like to sing. So I distract her by bringing her tea and singing with her while she bathes. The things we do. A true story from Robert, a Bayshore caregiver. After I'd get Jack's lunch ready, we'd sit at his back window and birdwatch together. Sometimes he'd share memories of being a tail gunner during the war. The stories he would tell. The things we do. A true story from Phyllis, a Bayshore caregiver. Bob is wheelchair-bound and finds it hard accepting help. He told me during the war they'd put their guns down at 3 p.m. for a cup of tea. So now, that's our daily routine, the things we do. A true story from Georgina, a Bayshore caregiver. Rose has dementia and used to be frightened when I arrived, so I placed a Post-it note with my name on it where she sits. Now she looks forward to my visits and greets me by name, the things we do.
Check out this Verbo.
Oh, man. Michael, they're your cousin.
Hi everyone, welcome to the webinar. So I have a quick introduction and then I will pass it off to our speakers. So every April, Parkinson Association of Alberta joins other like-minded organizations across the globe to bring people together in support of Parkinson Awareness Month. This April, we will be raising awareness of the impact of Parkinson's disease and Parkinson Plus syndromes to those who have received a diagnosis, the people who love for them and care for them, and our community as a whole. We are focusing on hope through research. Over the past 15 years, this community, through Parkinson Association of Alberta, has invested more than $1.5 million in support of Parkinson research in Alberta. Throughout the month of April, we are pleased to be able to bring you 6 noon-hour webinars that focus on research. You will learn how research has informed our work as an organization, as well as most of the several talent that early researchers of your financial statement have helped over the years. You will hear from some of the brightest minds in Parkinson treatment and ongoing research, all living and working right here in Alberta. Some amazing individuals living with or loving someone with Parkinson's disease will also join us to share their stories like you saw this morning. We hope that you join us in many of these virtual Lunch and Learn events as you can. They are free of charge and you can register online through our website or by contacting your local Parkinson Association of Alberta office. Thank you for joining us for our first virtual Lunch and Learn speaker series, presented today by our friends at Bayshore Home Health. Our co-presenters today are Dr. Allyson Jones and Charlotte Ryder-Burbidge, whose topics will be staying mobile in the community. This webinar will be recorded and all the information provided in the videos by Parkinson Association of Alberta and its featured speakers is furnished strictly for educational and entertainment purposes only. This service is not intended to be diagnostic, prescriptive, or replace the relationship, advice, or care of your physician. General questions about symptoms, treatment, available medication, complementary and alternative healthcare therapies will be fielded. If you have any questions during the webinar, please put them in the chat below and we will get to them at the end of the presentation. So I'm going to give a quick introduction to our speakers and then I will pass it off to them. So Dr. Jones is a professor in the Department of Physical Therapy with a cross-appointment in the Department of Public Health Sciences. She is also a fellow with the Institute of Health Economics. She has a PhD in epidemiology and an MSc in physical therapy from the University of Alberta, a BA in the Administrative Studies from the University of Winnipeg, and a BCS in physical therapy from the University of Saskatchewan. Prior to joining the Department of Physical Therapy at the University of Alberta, Dr. Jones completed a Canadian Institute of Health Research, Alberta Heritage Foundation for Medical Research postdoctoral fellowship in health-related quality of life. She received a New Investigator Award from the American Geriatric Society for her postdoctoral work. She has and continued to practice clinically as a physical therapist. Our other presenter, Charlotte, has studied the community of mobility for people with Parkinson's disease during her graduate research at the University of Alberta. Now she works as a science policy analyst with the Canadian Institute of Health Research, where she supports initiatives that promote the uptake of health research into practice. So thank you for joining us today, and I will pass it off to you guys.
Thanks so much, Emma. I'm going to share my screen and we can get started. So I am happy to be presenting with Dr. Jones today, who was my supervisor for my master's research at the University of Alberta. And that's the research that I'm going to be talking about today. So I did this research in about 2018 and 2019. So fortunately for me, just before the pandemic happened, because otherwise that would have really changed everything that we did. But I'm Pleased to be with the Parkinson's Association today because they were really instrumental in helping me do this research, and I hope that everyone joining today finds it interesting. So I'll start off with my presentation, and then I'll pass it off to Dr. Jones towards the end to tell you a little bit about some of the research that she's done as well. So my research is called "Does Parkinson's Disease Affect Life-Space Mobility? A Multiple Method Study." So first things first, what is life-space mobility? It's kind of a measure of community mobility, or how we move around in the community and how much we do that. So it estimates the magnitude or extent of travel into the environment, regardless of how one gets there. And the idea is that as life space grows, as you distance yourself from your bedroom, so kind of in concentric rings, so different rooms in your house, outside your house, in your community, further into town. And this is kind of how we start to measure someone's life space. Typically, life space is measured by a self-report questionnaire called the Lifespace Assessment, which asks participants to recall their movements in a typical week in the last month. So you'll see the 5 kind of layers of life space there, from the bedroom to beyond town. And for each of these different layers, the assessment asks 3 questions. So did you reach this level of life space? How frequently did you go there? Did you require any assistance? And based on participants' responses to this answer, we can give them a score from 0 to 120, 0 meaning that you were bedbound every day of the week, and 120 meaning that you were outside of the city every day of the week independently. So that means you have a really high life space.
Charlotte, I hate to interrupt. I just wanted to let you know we can't see your screen. I don't know if you shared with us.
Oh, are you seeing the presenter view?
No, we're just seeing you right now.
Oh, shoot. Okay. It looked like it was sharing on my end. Okay. How's that? Sorry, everyone.
Perfect. Thank you.
Okay, I'll skip to where I was then. Okay. Thanks, Emma. Okay, so ask these questions, we get a score from 0 to 120, and we get what we call a life space composite score. So that's your score of community mobility. And we also ask a few more questions about if you required any mobility aids or assistive devices or help of another person to reach these levels of life space. So of course, mobility is quite complex, especially for older adults. So researchers in the past have created this comprehensive framework for mobility in older adults to illustrate the type of factors that impact mobility. So the colors inside the cone each represent a different group of what we call mobility determinants. So those factors are physical, psychosocial, environmental, financial, and cognitive, and they're all kind of shaped by people's lived experience with their gender, biography, and their culture. And the model takes on this conical shape because the idea is that as you get further away from your bedroom into higher levels of life space, the task of being mobile in that area becomes more difficult. So for example, maybe going to the corner store to grab a bag of milk is a fairly easy task for some people, but going to the next town over to go to your granddaughter's hockey game might require a little bit more planning and a few more skills to be able to do that. So it's easy to understand how having Parkinson's disease might affect someone's mobility and how that experience might be reflected in the conical model of mobility that we just showed. So Parkinson's, of course, is accompanied by both motor and non-motor symptoms. Motor symptoms such as muscle stiffness and balance problems could clearly fall into the category of being a physical mobility determinant, but they could also interact with the environmental determinants of mobility. So, is the sidewalk uneven, or is the door really heavy to push open? So those kind of things can start to intersect to make it more difficult to move around. So while each experience of living with Parkinson's is unique, which is another reason why the conical model is an appropriate framework, the research today is really learning about how to live with the disease. Of course, mobility is an important activity of daily living, so let's talk briefly about why it's important to preserve mobility among people with Parkinson's. As I mentioned in an earlier slide, people with Parkinson's have to live with their disease. So when mobility is maintained over time, that helps people live a dynamic and independent life at home or another place of their choosing. In contrast, if mobility starts to decline, that can lead to physical deconditioning and a reduced social participation, which can threaten someone's independence and their ability to age in place. With the importance of mobility in mind, we designed this multiple method study to try to understand if and how life-space mobility is different among people with Parkinson's relative to people without the disease. The first objective of the quantitative component, so we did this with a survey, was to compare the life-space mobility of people with Parkinson's to a comparison group. And we expected to maybe see that the life-space mobility of people with Parkinson's was a little bit lower than their peers of a similar age in a community. And the second objective was to identify personal, social, and environmental variables that might factor into someone's life-space mobility. So what are the pieces of the puzzle that someone might have that would impact whether they have a high or low life-space mobility? And the objective of the qualitative component of the study, which we did with one-on-one interviews, was to explore barriers and facilitators to life-space mobility in this population with guidance from that model of mobility that we showed earlier. And the nice thing about using two different types of methods, so a quantitative numbers-based method in conjunction with a qualitative method that kind of starts to tell people stories, is that they really complement each other well. So we can compare numbers for an objective comparison of how someone's life-space mobility might compare to someone else's. And we can use stories from interviews to really help to understand the experience. So as I mentioned, we did a cross-sectional survey, which means the survey is just kind of a snapshot in time of someone's life. And then we did one-on-one interviews as well. So in total, we recruited 227 people living in the community, approximately half of whom had Parkinson's and dozens of whom were members of the Parkinson's Association. They were eligible to participate if they had been diagnosed for at least 6 months. And although we originally planned just to include people from Edmonton, we ended up expanding our recruitment area a little bit to include people from Calgary as well, and people from a Parkinson-specific exercise class in Camrose. And the comparison group was older adults living without Parkinson's disease in Edmonton, and they were recruited from seniors activity centers. So all of the 227 participants completed our life-space mobility survey, which was done in person, over the phone, or by mail, depending on what worked best for that person. The survey collected information about sociodemographics, so like who they are, what their personal characteristics are, their health status, their lifestyle behaviors, so level of physical activity, do they smoke, etc. And of course, their life-space mobility. And the Parkinson's group, in addition, responded to questions about how long they'd had Parkinson's, what kind of medications they were on, and their quality of life, measured with a tool called the Parkinson's Disease Questionnaire 8. And what we did with all of the information that we collected from these surveys is we started to compare the life-space mobility of people with Parkinson's to people without Parkinson's. And we were able to do this with a statistical method that we call regression modeling, which helps us figure out which factors that are a part of someone's life contribute or influence their life-space mobility. So the next part of the study was to conduct some in-person interviews. So 10 people with Parkinson's participated in these interviews. And they represented a mixture of people of different ages, different genders, and a mix of life space scores as well. And we interviewed these people with an open-ended interview guide with 4 questions. So the questions were, can you tell me about your experience with Parkinson's disease so far? What does mobility mean to you? can you tell me about a time when you had difficulty getting somewhere or that you wanted to or needed to go? And can you tell me about a time when you overcame a challenge related to your mobility? And the purpose of these questions was to really start to get a wholesome picture and kind of get some stories out of people about times when they maybe had challenges with their mobility and what type of coping mechanisms they had come up with to help to overcome some of those challenges. And so what we do with these interviews is we transcribe them word for word. So we write them all down, and then we do something called content analysis, which means that you start to pick out certain words or phrases that are similar to things that other people have said, and you kind of start to group things into meaningful categories to get kind of a list of different themes or concepts that people tended to talk about during their interviews. And we use the Conical model of mobility, so those different areas like physical, environmental, psychosocial, cognitive, to start to group some of these commonalities that the different interviews had to analyze the data and see what were the similarities or differences between the interviews that we had. Okay, so we're going to get into the first section of the results here, which are the quantitative results from the survey. So this table describes the characteristics of the participants in both groups, and I'm just going to talk about some of these. So you can see in the first line there, the average age of the two groups is fairly similar, about 71 in the Parkinson's group and about 75 in the group without Parkinson's. But there were a much higher proportion of men in the Parkinson's group compared to the other group, which is kind of expected just because Parkinson's tends to affect men a little bit more. And there were also differences in the amount of people who reported using a mobility device and reported receiving some sort of informal caregiving. So that would be like caregiving from a member of a family or something like that. So there were about 44% of people in the Parkinson's group that used a mobility device and about 15% of people in the non-Parkinson's group that used one. So you can already start to see there are some differences in maybe the types of help that people require between the two groups. People in the Parkinson's group had reported having had Parkinson's for about 8 years, and their Parkinson's disease 8 score, which you'll recall is the quality of life score, was about 27. So that indicates to us that maybe the people that were captured in our survey had about mild to moderate Parkinson's. Okay, so moving on to the Lifespace assessment, we found that the Lifespace mobility of people with Parkinson's was about 6 points lower than the participants without the disease. So those are the pink numbers at the top of the slide there in bold. And while we expected to see this kind of a difference, the difference wasn't what we call statistically significant. So we can't say really with any level of confidence that this difference wasn't just due to chance. So it might be meaningful, but we're not really sure about it, but there's certainly a difference there. And we can start to understand some of the difference if we look at the different levels of life space that people were reaching. So independent life space are the areas of life space that people got to without any help. So without something like a walker or without the support of another person. And when you start to compare the two groups, you can see that there are differences. So for example, there were fewer people in the Parkinson's group who were able to leave their bedroom without any assistance compared to the group without Parkinson's. And that trend kind of continues down the line into higher levels of life space. But then if we look at maximal life space, which is the percentage of people who can reach each level of life space, regardless of whether they needed help from an assistive device or from another person, we see that the numbers are actually really comparable, meaning that people with and without Parkinson's disease are reaching similar levels of life space, which is really good to see. It just means that they maybe need a little bit more help to get to those levels of life space. The next results are from the statistical models that we created. So again, this is where we were trying to see what different types of factors might contribute to someone's lifespace mobility. So for people with Parkinson's, we found that having a driver's license, having a high level of social participation, living independently and without a caregiver, and being comfortable financially all contributed to them having higher levels of life space. So these factors mean that they were able to get further into their community more often than people who didn't maybe have these characteristics. And in contrast, for people without Parkinson's disease, we found that, again, living independently and without a caregiver, not having a respiratory condition, and being comfortable financially were also contributed to higher levels of life space. So there are some overlaps in between the groups that had Parkinson's and that didn't have Parkinson's, but there are some differences as well. Next, we're going to talk about the qualitative results. And these results are kind of the ones that are almost more fun to share because it's little snapshots of people's stories that I think gives good insight into what living with Parkinson's can be like. So this first slide is really overwhelming and we're not going to go into details on it, but it just starts to show how we were mapping out the themes that we saw in the interviews, things that came up over and over again, how we started to map them into the model of mobility that we were using. So we took little pieces of conversations that we had with people and we were able to put them into these different themes. So first, I'm going to share some quotes from the participants that give a little bit of insight into some of the barriers to mobility that people with Parkinson's have. So I'm just going to read the quotes here. My anxiety level was so high that I couldn't drive. I did recognize that, and it's been that way a couple of times. And boy, I'll tell you, we lose our licenses, and every one of us agrees that is huge. And most of the people I know are in their 60s. You don't want to lose your license in your 60s. You've got a long way to go yet, hopefully. So these quotes kind of get to the themes of the different motor and non-motor symptoms that people have, and also their ability to participate in different social activities. So in the first quote, the participant's non-motor symptom of anxiety is interfering with his ability to drive. So he has to make a decision on a given day, whether he's going to go out whether he's going to drive somewhere or whether he should stay home. And in the second quote, this participant gives us a glimpse into what conversations surrounding driving are like for people with Parkinson's, who are still on the younger side and are probably still leading very active and social lives. And this participant felt strongly that losing her license would mean that she would have difficulty maintaining the level of mobility that she currently has. I used to be able to run and jog and kick a football and soccer ball with my grandsons. I don't see them very much. They live 10 minutes from here, but they want to play and I can't, so I don't, and we're drifting apart. And so this quote the quote by this participant offers a good example of how disease symptoms can directly limit someone's social participation and therefore their mobility. So his inability to play with his grandsons the way that he used to means that instead of leaving the house and going to visit them, he stays home. And of course, as these social ties weaken, there may be fewer opportunities to participate with people in the future. If there's too many people around, like a hockey game, sometimes the concourse is really quite crowded. I can't take big steps, so I take micro steps all over the place, and that it's hard to keep your balance when you're doing that. It's just difficult to move around when the crowd is that bad. So this gets at the theme of what we call challenging physical spaces and kind of the coming together of someone's Parkinson's symptoms and then also the environment around them. So, you know, that feeling of maybe not being able to move when the space is quite crowded, that's those two things coming together. Now we'll talk about some of the facilitators to mobility that people chatted about. I've started to plan my excursion around my medication schedule. My meds seem to wear off in 3 to 4 hours, so I'm always thinking ahead about where I'm going in 3 or 4 hours. where do I have to be? You know, if I have to be somewhere at 7 o'clock, what is my pill schedule? What will I be taking at the time? Will I be okay? Will the pills be working? Every place I go, I have a route planned so that I know where the parking lots are and where there's a coffee shop or something, and I can get out of the car and wait for the shaking to go away. So both of these quotes are about planning excursions, and that was a theme that definitely came up through the interviews, was that once people get to know their symptoms and their bodies a little bit, and potentially how their medications respond as well, they can start to make plans around those things that mean that they don't have to skip out on the things they want to do. They just have to maybe reorganize their timing a little bit. So in this quote, I asked, can you please tell me a little bit about the people that support you in your Parkinson's? And the participant said, well, first and foremost, my wife, who's very forceful at getting me to exercise, and she doesn't want to take ownership of the disease. That's my task to work on, but she will support me in anything that I choose to do. And this was another really common thing that came up during the interviews, was to support people in the lives of people with Parkinson's, and how those people offer support in a beneficial and facilitating way. So this is a good example in this quote here. And lastly, we got really good insight into the different types of coping mechanisms that people had come up with over the years to help with their symptoms. So in the first quote, someone talks about doing a step side to side if they feel like they're going to freeze, and I think they find that that helps them. In the second quote, this participant talks about doing karaoke in the wintertime to help with his voice. The third participant talks about how beneficial the walker is to allowing him to get around. And finally, exercise as well. So next, I'm going to talk about the key findings from all this information. So when we take it all together, what did we learn from this research? We learned that Lifespace mobility of participants with Parkinson's is not statistically different than participants without Parkinson's, although, as you'll recall, it was slightly lower. So participants with Parkinson's relied more heavily on assistive mobility devices to maintain their mobility relative to people without Parkinson's. So people with Parkinson's are as able to get around and get to the places that they want to go. They just need a little bit of extra help. Next, we learned that participants with Parkinson's who had a driver's license participated socially and were comfortable financially, and reported not having help from a caregiver had the highest level of Lifespace mobility. And the qualitative findings, so the findings from interviews, supported the importance of driving. Lots of people talked about how still being able to drive or not being able to drive influence their ability to get around. And finally, we learned that the Lifespace mobility of people with and without Parkinson's disease is explained by a different set of factors. So something that we always do when we finish research is we spend some time thinking about what we did well and maybe what some of the limitations were of the research, so that they can be improved upon next time, or so that people know maybe where some possible bias creeps into the research. So some of the strengths of this project were that it is an emerging area of research. The concept of using Lifespace to quickly and easily measure someone's community mobility is starting to become more popular. It was a novel multiple methods design, so you don't often see this bringing together of quantitative and qualitative results to start to tell a story. And finally, we used a comparison group. So those were the folks without Parkinson's disease that we were able to use as a comparison to see if there were any differences. The first limitation is the cross-sectional design of this research. And that means that we can't assess the directionality of these relationships. So, and I'll talk about this a little bit more on the next slide, but that's certainly a challenge. Next, there was some possible selection bias in both the Parkinson's and the comparison group, just based on how we recruited people. So for example, if you're recruiting someone from an activity center, there's a good chance that they're already more socially active or more physically active than other people in the community. Next, although the Lifespace assessment has been thoroughly validated in other populations of older adults, it hasn't been used in Parkinson's before, so we don't know if there are any differences in how the tool should be used when it's used on a Parkinson's population. And finally, we didn't measure the cognition or disease severity of people with Parkinson's, which of course is very important to understanding their ability to move around. So this slide illustrates the problem with cross-sectional research. So there's a meme here and it says, "This is a picture of an asteroid crater in Arizona. Look how close it came to hitting the visitor center." And if you take this picture and its interpretation at face value, you could be like, oh yeah, the asteroid was really close to hitting the visitor center. But if we think about it a little more deeply and maybe we do some background research, we can probably come to the conclusion that the visitor center was built after the asteroid. But that's kind of the problem with cross-sectional research, is when you just see a snapshot, a picture of something in time, it's hard to determine what happened first. So for an example for our study would be the relationship between social participation and life-space mobility. So based on this study, we can't say that people who are more socially active have higher life-space mobility, and we can't say that the opposite, which would be that people with higher life-space mobility are able to be more socially active. And so without knowing what comes first, it's hard to know where to target the efforts of an intervention that you might have. So for future research, we should further examine characteristics in the built environment. So that's the community or the spaces around us that facilitate and restrict mobility for persons with Parkinson's. We should try to untangle the relationship between social participation and mobility. So that's kind of what I just referred to. And we should examine the impact of cognition and disease severity on life-space mobility, because they're very important factors. And we should objectively measure life-space mobility of people with Parkinson's using something like a GPS, because of course, anytime someone is filling out a survey, it's hard to be 100% accurate about remembering where you went in the last month. And so this slide is just kind of a screenshot of this research being published. So it was just published in January of this year, even though we finished it a couple of years ago. So it's now out in the research community, and we hope that it will be able to inform other researchers that are looking at similar problems. Now, of course, something that you might have been thinking about during this presentation is how your life space mobility might have changed during COVID, when particularly at the beginning, we were all expected to be home and not going anywhere. So there hasn't been any research that's looked at the changes in life space mobility of people with Parkinson's during COVID, but there has been research from other groups of people, such as older adults. So there were a couple studies, for example, from Brazil or Finland, that showed that life space mobility of older adults decreased between 10 and 25 points during COVID-19. So that would be like a 16 to a 40% decrease in someone's life space during COVID. And the greatest decreases in life space mobility were seen amongst older adults who lived alone. And although we didn't see this factor come through in the presentation today, one factor that has been found in other studies to link closely with life space mobility is physical activity. So for example, the number of steps that someone takes in a day or their time spent in moderate or vigorous physical activity can relate to their life space. So if they're more physically active, they're more likely to have a higher life space. So that's my little segue to get ready for Allyson, who's going to tell you a little bit more about some of the research she did with physical activity among people with Parkinson's.
Okay, great. Thanks so much, Charlotte. It's always nice to hear all the hard work that you put in has come to fruition, and to be able to share it not only with the research community, but with people who have Parkinson's, and just get people thinking. And so I thought with this presentation might talk about physical activity as well. And just a little blurb as we're kind of nearing our end, that a few years back, we did a study. And you may know, and I'm looking at Charlotte to kind of switch the slides, thanks, is that you've probably heard that, you know, you have to have about 150 minutes of exercise per week, and that's a moderate, vigorous intensity aerobic. And then there's also this other one, 150 to 300. So in other words, you got to keep active. However, it's also not only the aerobic, I'm going to put on my physio hat too and say you also need the flexibility. You also need kind of the strengthening, the coordination activities. So this looks at the 150 minutes is basically the aerobic, making your heart work, getting your muscles and your joints working. But I do emphasize to the flexibility aspect of it as well as the coordination aspect. Now they also too, with the research, this is from the Exercise Physiology Group Association in Canada, as well as the States and such, who've come up with this. But they're also, how do you, what are other ways of measuring your physical activity? And it seems as if that 5,000 steps per day is a breaking point between sedentary and active. And we all heard about the 10,000 steps. However, that's has been a number that has been thrown out. But to look at the sedentary versus the active, there's more research that says that it's 5,000 steps. That's not to negate. Aim for 10,000 would be great. I believe they say 7,000, 7,500 to 10,000. Okay, so looking at now our particular study that we did. This was a few years back, and I don't know if any of you know Margaret Wheeler, who has a physiotherapist who has worked with patients or people with Parkinson's over a number of years. She was involved, and as well as Bob Hanel, who is an exercise physiologist. And so what we did with this, let's see, thanks, is that we recruited 11 people with Parkinson's, 7 men and 4 women, and their age was about 62. And they were a relatively healthy group with minimal, moderate to minimal disability. And we had them wear what they call a sensor armband, which is kind of like an actigraph that measures the intensity as well as the steps of per day. And we had them wear it, I guess, for 4 days, but then we were able to get 2 days of solid activities. So the only time that you couldn't wear it is, you know, when you had to have a shower, you're going swimming or whatever, anything water. And so we looked at what their activity, we actually measured it, unlike the Lifespace mobility in which we asked people to recall. This we actually measured by wearing this big armband. We also looked at their fitness level. And so we had people on the treadmill and measuring the oxygen that they were breathing in and out as they walked at different levels on the treadmill. So you'd expect that if you were working really hard, you're going to be breathing in a lot of oxygen, and you'd see your max, what they call the maximum VO2 increase. So we looked at the fitness level as well. Okay, and what we found, you'll have to disregard some of these numbers here. So what we found was that people wore the monitor, which is really nice, for almost the full day. So that was wonderful. And of that day, 83% of the day was spent in sedentary activity. So looking at the energy expenditure that they had, so it indicated that it was a sedentary activity. So 17% of that day, and I'll draw your attention to the pie diagram here. So this actually of the activity, that 17% of the day activity, that the vast majority, 79% of that 17% was in light activity, and nearly 20% was in moderate, and very small amount, 2%, was spent with vigorous activity. And I think, when you talk about vigorous activity, people will say, if you're walking or jogging or running, you can't keep a conversation. You're just breathing so much. Whereas with light activity, you can have a conversation. We also, their step counts. When we look at this activity, that their step count was a little over 5,000 steps per day, which was interesting. Disregard this 48 and 38 and 14%. But what I want to also mention that when we look at the fitness level on the treadmill, that in general, it wasn't the best. That basically the majority of people were in the lower 50th percentile of fitness relative to their age and their sex. Okay, and so what this is telling us is that the activity, like the general population, is not the best. But when we ask people about their overall health status, it's a series, there's standardized questionnaires with ranging from 1 being perfect health and 0 very, very poor. And that the series of questions, you tally it up and you get a score on this scale. And that with this, because it's a generic health measure, that you can compare across populations. And so what we did with our fitness group was that we had them answer the questions, and their mean score was 0.66, keeping in mind that the overall health of 1 is perfect health. So they weren't too bad when it came to rating their overall health, but in comparison to some other analyses that we did, interesting, Stats Canada, I think it was in one of their cycles, I think in 2004, they'd asked people if they had Parkinson's or not. And so that was a real nice segue to looking at the Canadian population as far as how many people had Parkinson's. And then within the Stats Canada, they used the same generic health measure that we used for our groups. And so it made it for a nice comparison. So when we looked at the Stats Canada cohort who said that they had Parkinson's, their mean score was 0.56. So that kind of certainly indicates that we had a fairly good group of those 11 people. Whereas with the Stats Canada, they probably were a variety of different how they were managing. We also compared just to give you an idea of the general population, their score on this scale was 0.87. So it just gives you a barometer to see how people who've had Parkinson's, how they rate their overall health. So, the findings here suggest that with this little group that we had, were not as active as they believed they were. But this could be related to, because we asked people how active do they think they were, and then we measured it. And the thing is that we were thinking that maybe it's the amount of effort required to perform an activity, why we didn't get how the perceived activity or effort going into the activity versus what they could actually do was a little skewed. And maybe that people are not able to do so much, and they're interpreting that activity as a lot of effort, that this was really vigorous activity that they were doing, when really it was either light or moderate. And I think this also to their scores that we're seeing is what is also reflected as their overall health status. Just gives you a barometer to see where how they rate their overall health relative to others. And so yes, that they're rating it lower. It's likely harder to do activities, but they're trying, and the fitness level, the step count, is not comparable to what we see with other populations. So it was nice to be able to evaluate and put some numbers to it. And then we can go forwards and report, so other people can see where Parkinson's is how they're rating themselves and how active they are. So I just wanted to share that with you for today, relative to the self-reported Lifespace mobility that Charlotte looked at with her study.
Thanks, Allyson. And I'll just say too, I didn't talk about this in my slides, but we also sort of asked people about their physical activity in the survey that we did. And it was a simple question of, do you think you're getting 150 minutes per week of physical activity? So that would be kind of aligned with physical activity guidelines. And we found that between the Parkinson's group and the group without Parkinson's, basically the same proportion of people reported meeting those guidelines. So it wasn't, we didn't really see any meaningful differences between the two groups in our case. And then the idea of physical activity affecting life space mobility didn't come through in our statistical analysis, whereas it has in other research done by other people. So just thought I'd tag that on to the end because we are finished up here. So thanks to everyone for coming today and for listening to our presentation. Thanks, Emma, for letting me know that my slides weren't showing at the beginning. And Allyson and I will be happy to take any questions of any kind that you have about the research that we've done.
Great, thank you for presenting. Even without the slides at the beginning, it was still a great presentation. I've got a couple questions here. So the first one is, it kind of came up a couple times. How come you guys chose to do research in Parkinson's?
Oh, me first.
Sure, go ahead.
So prior to starting my master's, I was working at Dalhousie University in a medical neuroscience lab, and we were working not in humans, but on models with mice, and we were trying to understand movement from the spinal cord. And so that experience is what kind of piqued my interest in mobility and neurological conditions. And at the same time, I knew I kind of wanted to take like an epidemiological or a public health focus. So that's kind of how I ended up applying to the School of Public Health at the University of Alberta. And Allyson and I kind of matched up together. And so she had some experience working with people with Parkinson's. And so that's kind of how all this came about.
Mm-hmm. Yeah, and I'm had practiced as a clinician for several years. I won't tell you how many, but prior to going into academia, and I was a neurotherapist, and so certainly have worked from a clinician's perspective with people who have Parkinson's. However, when I did my PhD, I couldn't find a supervisor who was in neuro, so I didn't. However, the longer story was that it's always near and dear to my heart, and I certainly knew, and maybe some of you already know, Marguerite Wheeler and Dr. Wayne Martin, and he's a neurologist here, and Marguerite, as I mentioned, is a physiotherapist, and they were associated with the Movement Disorders Clinic. And just talking to them, about, first of all, the research that they did, and then also how little work in epidemiology of Parkinson's there is. And we just even the basics of looking at what the incident rate is of Parkinson's in Canada. And so we actually published a study a few years back that actually looked at the incidence, the number of new cases per year of Parkinson's in Canada. So I guess, I enjoy, certainly with research, it's developing those collaborations, but then also to realizing there's really gaping holes when it comes to epidemiology with Parkinson's. It's becoming better, but there's still a lot of questions to be answered with Parkinson's. So this is what drove me was the positive relationships, working relationships, certainly with students like Charlotte, as well as clinicians and fellow researchers, and just kind of the gaping holes of that, all the work that needs to be done from an epidemiology perspective with Parkinson's.
Sorry, if I can just add one more thing too. Also kind of from like an emotional or like a human point of view, I feel like mobility is one of those things that everybody takes for granted until something falls out of line and you no longer have it, or it's been affected in some way. So I think that even before I started working around questions of like working in the research area of Parkinson's, that's always just kind of something that I had thought about. And it's it's kind of said that like we should be designing our communities in our spaces and our programs to accommodate the people who have like the most challenges, and that's not something that we do. And so this was a really interesting project to me because it looks at all the different components of the world that we live in, social, environmental, etc., that need to be worked on to make it more accessible for people.
Yeah, definitely. Thank you so much. We appreciate having you guys complete some research for our little Parkinson community. It means the world to us. Some of the other questions on here: how does one join a research group, and are there follow-up to these studies that you guys had mentioned?
Of course. And one study that we're trying to get off the ground is looking at mobility and measuring, like with a GPS and using an accelerometer, so we can get a better measure of the number of steps. And in a larger population. So I guess we tend to go and reach out to associations like the Parkinson's Association to ask for volunteers and put it, in the newsletter and such. So we have a few, and there's certainly a number of, as you probably know, at the University of Alberta, neurologists who are certainly doing wonderful research. But not too many are looking at mobility. And I think this is where, it's really good to reach out to the community and ask for volunteers. So I guess that's the primary one I would say. So keep your ear open. And I think too, we, certainly with this study, looked at Calgary as well. We were able to recruit through Calgary and our linkages. So this was wonderful.
You might have a long list now of people who are ready to do some research with you.
Excellent. And I guess too, like when we did that study in 2012, looking at physical mobility, hardly anybody was looking at that in Parkinson's. And, it's reassuring, to see now physical activity is becoming more publications. It's being raised to a higher level right now. So that's reassuring to see, both within the community as well as within research. So
definitely. Yeah.
And I will point out for Calgary in particular, one of the groups that was helpful to us is called the Calgary Parkinson's Research Initiative, which some people may be familiar with, but from my point of view, it was really wonderful because they have just kind of a list of people who have agreed to want to participate in research. And so I was able to reach out to the coordinator, and they were able to kind of share the research with the people who were on that list. So if you want to be just kind of put on a generic list to be reached out to, if there's a research project that you might fit the criteria for, that would be one way to go about it. And I think too, and maybe Emma knows more about this, but I'm pretty sure that the Parkinson's Association website has a participate in research link. So there's a few different ways to kind of put your name out there if you want to be contacted.
Yeah, so I'll just add, if you're interested in participating in research but not sure where to get started, just contact your client service coordinator and they can direct you in the right spot. Like you said, our website's got some research, and then most of the universities, the major universities here, have some research, like the Calgary Parkinson Research Initiative. So thanks, guys. I know it is just after 1, so there's just a couple more questions we'll get to if you guys have the time. One of the questions is there any preferred exercise for people with Parkinson's?
You know, and I guess maybe I'll step in and answer this from a physio perspective. I would say reach out to your physiotherapist, because the thing is, there's a, you know, as you know, with Parkinson's, there's a lot of other comorbidities, and you have to respect. So it isn't just kind of the Parkinson's. There's all these other conditions that may influence your activities, and so this is where it'd be nice if you could have you know, check with either your physician or your physiotherapist to find out what type of activity. And I'm just going to put a word of warning there too, because I've kind of come across this, is that you have to respect fatigue. That I have found that people will push themselves if they get on an exercise program, and especially too if they're, you know, still trying to figure out, you know, what they're, you know, because as you know, Parkinson's is very dynamic. And so knowing your body, knowing the fatigue and respecting the fatigue. So unlike, you know, some of these top athletes who'll push right through, you know, with their training, respect your fatigue, because you need to keep moving for the next day and the next day after that. So I just put that word of warning, but because everybody is so individual, I would recommend talking to your physiotherapist or your physician.
Yeah, I think that's good advice. And yeah, I really like what you said. Be gracious with your body. And, you know, sometimes you are fatigued, and that's okay if you can't do an exercise that day. I will just add too, if you are interested in getting involved in exercise and not sure where to start, we have some exercise programs. So you can always, again, give your client service coordinator a call and they'll find something that works well with what was recommended by your healthcare team. The next question is for Dr. Jones. The results of your pie chart, what would be the ideal sedentary percent versus the 79% on the graph?
Yeah, well, the 79% is of the 17% of the light to moderate activity, just kind of identifying that, you know. And I guess I'll step it back a bit and say the ideal from a functional perspective that you can take away is using your step count. As I was saying, that step counts that are less than 5,000 tend to indicate that it's a simple way of indicating whether you're sedentary, spending a lot of time in sedentary time. And so the fact that our group had max or an average step total of 5,400 really doesn't say they're really kind of over the 5,000 too much. And this was a fairly, they rated themselves as being fairly active. So we're aiming for 75 to 10,000 steps. So also too, yeah, so I would kind of preface that by keep it functional and just kind of let's talk about number of steps that you take.
If I may add to the World Health Organization, we showed those little graphics of the physical activity guidelines. The WHO changed their recommendation in 2020 to say that you should aim for 10-minute bouts of activity, to saying that every minute of activity in a day that you can get counts towards something meaningful. So if you just think of any little moment in the day where you can squeeze in a little bit of movement, that's beneficial according to the World Health Organization. And they have really good resources online for what types of activity you should be aiming to get, and including for people with different types of chronic conditions. So if you're interested in that type of information, there's really great stuff online.
Okay, that's great to know. I feel like everyone is gonna hopefully get up and get moving after sitting for an hour for a presentation. So there's just one more question. What can someone do if they're beginning to notice a change in their mobility?
Good question.
It's a hard
It's a
I
little
saved the best
tricky.
for last, I guess.
Yeah, yeah, it's a little tricky if you're noticing, and I guess it all depends what you're noticing. Is it that you're noticing your balance? Is it that you're noticing your flexibility? Is it that, from a cardiovascular perspective that you're noticing it? So this is where it's worthwhile having a good relationship with your physician and seeing, is that a sign of other things? I guess I'm a firm believer in kind of looking at the whole body and what exactly is your body trying to tell you if you're starting to have problems with that. So having good communication, and if it's really something you're really concerned about, like this is not right, again, reaching out to your physician or even your physiotherapist as well, if it's kind of concerning mobility, and whether you need to look at some type of program or assistive devices or whatever.
Good. Okay. Yeah, keep your healthcare team as your best friend and keep them connected, I think, is the best advice. Good. I think that's all the questions that we have. So thank you so much for coming. Thank you for sharing your knowledge and participating in our Parkinson Awareness Month webinar. We're happy to have you and happy to have your research here in Alberta. It means the world to us, like I said. So thank you so much. And thank you to everyone who was able to participate today. We do have another webinar coming up next Wednesday on April 13th. And so if you're interested in registering, you can just go to our website, like I mentioned earlier, and register online, or you can give our office a call if you have any questions. So thanks so much, guys.